This technique allows you to intubate a patient through a supraglottic airway device in the event of a failed tracheal intubation. It is one of the potential airway management options following a successful Plan B in the Difficult Airway Society's Difficult Intubation Guidelines. That is where you can oxygenate and ventilate a patient through a supraglottic airway device. To perform the technique, you'll need the following pieces of kit: an Aintree Intubation Catheter set, a slim ambuscope, a standard cuffed oral endotracheal tube, cut to the desired length but no smaller than a size 7, and a laryngoscope blade. This is an Aintree Intubation Catheter set. Firstly, it includes an Aintree Intubation Catheter, which is essentially a stiffened hollow tube. It will fit over the top of a slim ambuscope, but not over a standard sized ambuscope. Before you start, you need to preload it on the scope as follows. And secure it at the top with a piece of tape. Also inside the kit is a swivel connector with a bronchoscopy port. You need to exchange this for the angle piece on top of the eye gel. Like that. And for completeness, there's also 2 RapidFit adapters inside the kit. These attach to the top of the Aintree catheter and could allow you to supply oxygen through the lumen into the trachea if railroading the endotracheal tube was becoming a prolonged situation. Ensure adequate anaesthesia, muscle relaxation and ventilation through the supraglottic airway device throughout this procedure. For the purposes of this video, we're using an eye gel, and I'd recommend that you use any appropriate second-generation supraglottic airway device. An assistant should immobilise the eye gel for you. Then introduce the ambuscope with the preloaded Aintree catheter through the bronchoscopy port on the swivel connector. Advance the scope through the eye gel, emerging through its aperture. Then visualise the glottis. If you emerge from the aperture of the eye gel and cannot see any anatomy, it's often helpful to pull the eye gel back by 1 centimetre or 2 and try again. Then visualising the tracheal rings followed by the carina. Do not advance beyond this point. Next, you'll need to remove the tape and withdraw the ambuscope, leaving the Aintree catheter in place. Note the depth of the Aintree catheter and fix it in position with your hand. Then disconnect the swivel connector from the breathing circuit. If you're using a supraglottic device with a cuff, ask your assistant to deflate the cuff at this point. Now carefully withdraw the eye gel over the Aintree catheter, providing counter pressure to hold the Aintree catheter in position. Once the eye gel is clear, you can grasp the Aintree catheter in the mouth, noting its position at the lips. For the purposes of this video, I'm going to demonstrate the next stage with a standard Macintosh blade, but I'd advocate using a CMAC in reality. Insert the CMAC blade into the mouth and obtain the best view of the glottis that you can manage. Ask an assistant to thread the endotracheal tube over the Aintree catheter and stabilise the Aintree catheter whilst you railroad the ET tube into the trachea. Ask your assistant to remove the Aintree catheter, then connect the breathing circuit to the endotracheal tube, inflate the cuff, and confirm tracheal placement using capnography and standard clinical checks. Because you won't necessarily have seen the ET tube pass through the cords, I'd also advocate using the ambuscope at this point to confirm position of the ET tube above the carina.